And I am a registered traditional Chinese medicine practitioner and acupuncturist in downtown Toronto, founder of Alive Holistic Health Clinic, and author of Pathways to Pregnancy. Oh, here it is. So here's my book. But today, it's not about my book because I really am excited guest on my 53rd Facebook Live post. And tonight, I have a very special here. This is Dr. Not Broken. And as you can see, it's actually, oh wait, I'm going the wrong way. Here it is. We're going to talk to Dr. Lora Shahine. And before I introduce her, who's sitting here right in front of you with her beautiful face, Lora is MD and is a certified reproductive endocrinologist currently practicing at Pacific Northwest Fertility in Seattle. She completed her medical training at UCSF and Stanford University as clinical faculty at the University and director of the Center for Pregnancy Pacific North. She provides excellence in patient care, teaches the next generation of women's health, and continue research into her field. Dr. Shahine is an accomplished author of many blogs, over 50 peer-reviewed articles, and 2 books, Planting the Seeds of Pregnancy, an integrative approach to fertility care, and Not Broken, an approachable guide to miscarriage and recurrent pregnancy loss. The book, unfortunately, I actually don't have your other one, so I apologize, but I just read this one, and I love it, and so I'm really excited to have you here. And the reason being is because, you know, I'm in the holistic field and you're in the Western allopathic field, and truly we can really meet and integrate our 2 systems of medicine.
Absolutely.
So, yeah, and so I'm really excited to have you here. And as an expert on miscarriage and recurrent pregnancy loss, we have lots to cover because it's a very common back up. What are pregnancy loss?
Can you say that one more time?
What?
I'm sorry, it's just a little bit of the connection is lost.
Okay.
Just as.
See, I'm asking, let's just make it bare bones and go back to what is recurrent pregnancy loss? Yeah. What is your definition?
Yeah, thank you. I'm so happy to be here, Mary. I really appreciate it. So traditionally, recurrent pregnancy loss is defined as 3 clinical miscarriages, and that will instigate a provider in the Western field to start doing an evaluation. We've really learned a lot, and the definition has changed a little bit. In about 2012, American Society of Reproductive Medicine changed the definition and said, really, if someone's had 2 pregnancy losses, then it's really important and worth doing an evaluation in order to find something we might be able to prevent that 3rd loss. So providers might still kind of go by that definition with the textbooks, but really providers can absolutely start an evaluation after 2.
And care, I think it's important to start early care because care you're a mess, you're a disaster because, and you know, we had a conversation earlier before we started this, but when a woman experiences not even just 3 miscarriages, but even after 1 miscarriage, oftentimes there's a sense of, I have failed as a human being or as a woman. Oh. And there's pressure over history and time as well. So yeah. To get some...
Absolutely. So from the beginning of time, for however long you want to think that we've been here, anything that has to do with family building and reproduction, if anything goes wrong, it's got to be the woman's fault. And miscarriage, people don't really realize how common it is. It's estimated that about 25% of pregnancies that are clinically recognized stop developing and end in miscarriage. And so that could be as many as 1 in 4 couples that are trying to conceive at some point will have a miscarriage. And it's not something that people talk about a lot. It usually happens before you're showing or before you've shared with a lot of people. And it's very isolating. And if you don't realize how common it is, you feel like you're the only one that's happened to. And it's easy to blame yourself. You want so much to start your family or to complete your family. And when it's not going well, it's easy to try to have self-blame. It's really a coping mechanism, because if you can center in on what you did wrong, whether it's stress or a glass of wine before you knew you were pregnant, then you can isolate what that was, change it in your next pregnancy as a way to avoid going through all this emotional pain again. And so, the self-blame and the doubt kind of really plays into what a lot of people are feeling. And that's one of the whole reasons why I wrote this book. And the title is, Not Broken. So many women come to me, they feel like their body's broken, their body is rejecting pregnancies, they're doing something wrong, and I'm trying to change that conversation.
Mm-hmm. And that's why I gravitate towards your book, because I am in 100% complete alignment. We work well together, right? And it's story. So let's talk a bit more about that. Let's bring it right up front and have that self-blame. We want to really throw it back in there about the male factor equation. So I would love for you to address that too.
Sure, just to talk about the men's role, the other half. Yeah, so we really honestly don't know a lot about the male factor or men's role in miscarriage. And that is because we've been focused so much on women because of our society's bias that it's got to be the woman's fault. So there's actually very little research into the men's side, but they are the other half. And we know that the most common cause of miscarriage in the first trimester is a genetic issue. It's a chromosomal issue. And men are half of the genetic equation. So we don't have a lot of good tests to show or prove that males are a part of the issue, but we need to learn more.
So, oh wait, let me put I am. We do need to learn more. We really need to know that it's not fault, right? And there, so that feeling a less sense of self-responsibility.
Yes.
And having yourself be proactive along with your partner. And I think the partner sometimes, actually, I want to address this. Here's what I see sometimes. The couple goes to the clinic, and the man, just from their sperm analysis, may look as though it looks okay. Like billion, it's like borderline. But you know what? IUI or IVF will just take care of that.
Oh.
And that's the man just doesn't have to do much.
Right, I know. So it is reproduction and research and testing. It's very female focused. The semen analysis is so basic, and very little information really comes from the semen analysis. The most important thing from a semen analysis is their sperm, right? Is there sperm? Is there about enough? And is it moving? And sometimes we learn a little bit about the shape, but there's nothing from a semen analysis that's really going to tell us anything about miscarriage risk. And so we're trying to find tests for men, and some people will talk about DNA fragmentation and looking at sperm, but those studies really have not shown a higher risk of miscarriage. There's some looking into and investigating maybe the epigenetics of sperm. There's some very new tests, but there's really not much that we can do. And so whenever I'm counseling a couple and we're looking, and I sort of say, listen, the semen analysis looks good. There's an adequate count. All these numbers look good, but that doesn't mean you're off the hook, right? Like and don't walk out of here with a big head and your ego saying like, yes, I've got swimmers, right? So I just sort of say it takes two people. This is one sample. The sample looks good, but it really, every sperm and egg are different, and you're in this together.
Thank you. Thank you for this, because I want every woman that's watching this who is trying to conceive right now to have your husbands or your partner watch what Dr. Lora Shahine just said, because this is the biggest piece. Because when men just think that they're off the hook, like you take a little thing, yeah, it looks fine, but it's just visible. Like we really don't know what's going on underneath. So thank you for saying that, and actually be more proactive and great sharing the responsibility, right?
Right.
So, okay. So now back to the recurrent pregnancy loss. What is your view with regards to autoimmune factor?
Sure. This is something that comes up a lot because it's a part of self-blame. So there's a lot of this about, kind of on Dr. Internet, and I talk to patients about it a lot. So an evaluation for recurrent pregnancy loss is really focused on anatomical issues, hormonal issues, some genetics with the parents, and the only immune issue that's really been proven to be associated with recurrent miscarriage is something called antiphospholipid syndrome. And that's a very specific diagnosis, and if it's diagnosed, there's a very specific treatment. But there's a lot of people out there that are focused on testing a lot of different tests that really have not been proven, and it really sort of gets into this self-blame, and it's a really easy sell to women. You are having recurrent miscarriages. I think it might be that your body is attacking, either the embryo or it's attacking your husband's sperm. There's something wrong with you. Therefore, we're going to have to give you these, high dose steroids or really significant treatments that will shut down your immune system in order for you to accept the pregnancy, because there's obviously something wrong. And the problem is that the majority of miscarriages are something with the embryo. We know this. If you test pregnancy losses, 60 to 80% of the time in the tissue, you'll find that there's a chromosome imbalance. And so we're giving these women these high-dose steroids and other treatments that have serious side effects and impact, and just playing into their guilt without much benefit. I am humble, and I am learning, and I am keeping my eyes and ears open. But someone's really going to have to show me and convince me if a treatment has the potential of harm. You've got to show me that it's truly beneficial before I start giving it to patients. So there's got to be a balance, and we still have a lot to learn.
That's a really great and cautionary approach. And I find that, unfortunate to you, because you're not practicing this way anyway, but I feel like in the reproductive world, it becomes almost like cowboys and Indians, like things, right?
Absolutely.
Oh, sorry, I was just issues home.
No problem.
I'm falling asleep and I have to be more quiet or something.
Got it.
Okay. So then, if you have any kinds of, because women, no matter what, will say, what do you do as that first line of defense then for them in treatment under?
Sure, and let me just make sure I got your question right. So you're saying what is kind of the first line of treatment for recurrent miscarriages?
Yes, and along with that, fear of autoimmune.
Oh, yes. So first and foremost, I'm doing a standard evaluation to make sure that there's not something that I can fix. So if someone has a septum in their uterus, I can fix that. If someone has a thyroid imbalance, I can fix that. There are solid things that have been associated with miscarriage that we can treat. 50% of the time, we don't find an answer, right? Because we're testing the people that are getting pregnant when the most common cause of miscarriage is within the embryo. So it's shocking to people that they're going to finish this thorough evaluation blood work and anatomy checkups, etc., and then they're not going to have that black and white answer. And that's very uncomfortable for the patients as well as the provider. But it makes sense to me that we're not going to find answers within the parents if it's going on in the embryo. So then if you're not finding answers, people often will look for answers. They want to do something. They want to do an intervention so that they will make sure that they don't have another miscarriage. But my counseling is each time you conceive, it is a new chance. It's a brand new egg and it's a brand new sperm, and you don't necessarily have to do treatments that may be harmful. Now, empirically, they're non-harmful for most people way to sort of make the environment as best as it can without side effects is to consider low-dose aspirin and maybe some supplemental progesterone. Those two things are excellent immunosuppressants, and they don't have the side effects that a lot of the other things do. So progesterone is the dominant hormone in the second half of the cycle, and it's the dominant hormone in pregnancy, and it is in and of itself an immunosuppressant. Now, most people don't need extra progesterone, but you can't really figure out who those people are because when you do blood tests, it's very inaccurate. Progesterone is produced by the ovaries in a really inconsistent fashion, and so you could check it at 10 a.m. and it could be 5 and you're worried that there's a problem, and you could check it at 11 a.m. and it's 25 and you're like, oh, you don't need any extra progesterone. But you really can't use blood tests to tell what's going on in the uterus. And so I give it out to a lot of people with recurrent loss. And I tell people, listen, I'm probably over-prescribing this. Like if I give it to 100 women, I'm probably helping 3. And there's 97 women out there that are taking something that they don't need necessarily, but it's not harmful and it might help the environment. It's very theoretical.
Can you hear me? I'm having some technical difficulties again.
I heard a little something, but then I did hear your voice just then.
Okay. All right. So then in terms of progesterone, is there a carrier of choice, suppository versus oral versus IM, like intimate?
Sure. So studies show that the best way to get progesterone to the uterine lining is really either intramuscular injections or vaginal suppository. So in the United States, at least, there's not an oral progesterone that is really shown to kind of get to the uterine lining. And topical progesterone, that as well, has not been shown to truly help. And then any studies that do show a benefit of progesterone use for unexplained recurrent pregnancy loss has used either vaginal or intramuscular progesterone.
And I think this topic, because in Toronto, at least, I'm not sure about where you are or where anybody else is, but in Toronto, when someone does in vitro fertilization, meaning fertilizing egg outside of the body and putting it back in the body, there's this automatic go-to towards injectable over the suppositories. Insemination with suppository. With an IVF, they add in intramuscular injection. If you have an idea why they think that's better, because in my books, I say both are equal.
Right. So the difference is what the patient's treatment is. So if someone's doing a fresh IVF cycle and they're transferring embryos before they're frozen, if they're doing IVF and they've just had an egg retrieval, their own body is making some progesterone. And so what you're giving is a supplement. And in that case, we really do know that people need a little bit of extra progesterone because sometimes when you do the egg retrieval, you're disrupting some of the cells that make it. But you can do either intramuscular or vaginal. Now, in a frozen embryo transfer cycle, if the medication, the progesterone that we're giving is the only source of progesterone, right? So nobody's making it, nobody's ovulated recently, their ovaries have been suppressed, and they're doing a frozen embryo transfer cycle, then we do recommend starting off with intramuscular progesterone, and then they could maybe switch to vaginal later. So it's sure,
Why?
it's a little bit theoretical, but there are some physiologic studies that show that the way progesterone gets to the uterine lining in a natural cycle is very subtle. So it kind of starts off a little bit low and gradually builds up as the corpus luteum continues to make more progesterone. And so intramuscular delivery of progesterone mimics that gradual increase. It kind of gets into the muscle and it's sort of delivered very slowly over time. And this is the progesterone delivery system we've been using for IVF for 40 years. The vaginal progesterone, which is newer, it gets to the endometrial lining almost immediately. And I know that there's studies out there saying that vaginal progesterone and intramuscular progesterone are the same in IVF. Those studies are really with fresh embryo transfers. The patients have some other progesterone on board. We haven't seen studies that have shown when someone's a recipient, right, or a frozen embryo transfer, if that woman is not making any of her own progesterone, we can't say that vaginal is better than intramuscular. And physiologically, the vaginal, when you do start it, it gets to the uterine lining immediately. So the worry is that the vaginal is advancing the uterine lining a little bit faster than intramuscular. So maybe if we figure out the timing and we do more experiments, we would figure out, because the embryo and the uterine lining, it's literally like a jigsaw puzzle. It has to be a really delicate amount of progesterone and estrogen interactions to sort of get that embryo to implant. So maybe people who are doing vaginal progesterone, maybe they just need to start a little bit later. But it's hard to do experiments when you know something works really well. How do you get people to do those experiments when it's their embryos?
Okay, so then I have one.
Yeah.
So at what point, I don't know if you yourself have had like intramuscular injections, especially with, right? Because it's viscous liquid, right? So it doesn't nice.
My backside was not the same for months. I get it.
Yeah. So how long can someone do this?
Yeah, I try to get my patients to do it until a positive pregnancy test. So that really could just be 16 shots because it's, you have the transfer on the 6th day of the progesterone and then you do the pregnancy test 10 days later. So if they can get 16 shots, then they can transition to vaginal.
Okay. I'm so glad that you get the whole shots thing because sometimes I feel like every doctor and every nurse should have them so they fully understand. Right?
Right. I get it. Right. And the standard is you have to have some sort of progesterone for at least, we do it for 10 weeks, but probably definitely 8 weeks. And that was really hard to do it every day that's really almost 3 months of everyday intramuscular shots. And so I get that. And so I think that the transition has worked beautifully in our particular clinic and practice.
Oh, so this is exactly what you do in your practice. That's great.
Yeah. And a lot of times, though, I will tell you that patients switch to the vaginal and then they ask for the shots back because the vaginal suppositories are just pretty messy. And they're kind of like, wow, that was just so easy to just get a shot in the morning and kind of go on with my day. So everybody's different.
Everybody is different. And I think those people, so this brings up prone to vaginal yeast infections. For sure, suppository is not the best thing because it can be irritating. Although sometimes we tell women to do it rectally, and that works just as well. But I'm going to tell you a little story about myself because I've done multiple IVFs, and I'll tell you when so you said you had your bump for like several months. I call them, they were that like shelves, and I swear to you, it was like over a year I had them. Horrible. So when it came time to I did a whole lot of IVFs, And the last one, when it was frozen embryo transfer, I said, you know what, I'll do whatever it takes, but please, I cannot do another shot of progesterone. So you met my daughter before.
Yes.
So she is a product of frozen embryo transfer, only vaginal suppository. So I didn't intramuscular at all.
That's great.
So it worked for me.
Great. Yeah.
But lots of great information. And I've actually asked patients, maybe you can ask your doctor and see if you can switch. And they always get fearful of asking. I'm like, it doesn't hurt to try, right? Like at least two. So I love it that you're doing exactly what I was thinking. And, you know, my patients to ask their doctors. So it's great. Thank you.
Good.
I don't know exactly has a question. No. Okay. They may come later. People watch it later, but it's really good if someone is actually on there as we go. But the other you should know is I find that because the topic of fertility is such a near and dear topic and a private topic, that a lot of people watch this behind the scenes, because as you put a like in there, then all of a sudden you're upfront and personal. People see your post. So I've found over the time it's watching, but really everyone. So I too, because some of my patients come in and tell me, I'm like, oh, I have no idea. Right, and so I really want to hear, because I'm adding a lot to this call, and having really good measures so that they're not left with, oh, you know, I feel like I'm desperate and I'll just do anything that the doctor asks me to do.
Right.
I really
Great. Thank
so
you.
thank you. Is there anything else that you really want to add in that like is to add about recurrent pregnancy loss?
Yeah, absolutely. I think something that's really important to understand is that we should remind patients that even if they're having losses, they have such a high chance of success just trying again naturally. So even if I don't do a single test or a single intervention, you know, like aspirin or progesterone, or sometimes we're doing in vitro fertilization with chromosomal screening, you know, for people with multiple, you know, chromosomally abnormal losses. Even if we don't do any intervention, people can have as high as a 70, 80% chance of a live birth after having 2, 3, or even more miscarriages. And so I try to focus on the fact that they're getting past all of these hurdles. You know, they're having fertilization, they're having implantation. The woman's body is accepting the embryo. And just at some point, there's probably some gene that just didn't get turned on, or a chromosome that was missing. And, you know, it just wasn't meant to be, and it just stopped developing. But they're really, every time you try, it's a brand new chance. And I really want people to do an evaluation, get educated. That's why I wrote the book, because I want people to have this knowledge. But the most important thing is that people feel hopeful. Thank you.
Being hopeful, absolutely, and that there are really great stories out there, and using intervention and no intervention as well, and that's where people like us in the complementary will come in as well, because going through this is so stressful. And as you had mentioned, when we're talking, you know, it is reality of the embryo, right? Like there's something wrong with the embryo versus, oh gee, there's something wrong with my receptivity, my uterus is not receptive. And so in a way, our environment also helps our bodies express these genes and the DNA. So I think we really do need to nurture ourselves both physically and emotionally and spiritually. And miracles happen, right? People do get pregnant, as Dr. Shahine said.
Yeah, absolutely. And I actually really appreciate your approach. And I do work with a lot of acupuncturists here in Seattle. And people often ask me, should I do acupuncture? Should I see a traditional Chinese medicine provider? And I say, listen, everybody's different. If you hate needles, you probably might not like acupuncture, but if you're interested, why don't you just, talk to somebody, give it a try, learn, and build your team, that it's good to have a care team and, providers, counselors to help you with your emotional health, acupuncturists to help you work on your nutrition and your self-care and bringing yourself into balance. As a Western medicine provider, I'm really good at making sure there's not an anatomic issue or a hormonal issue or something that I can fix. I can do IVF and screening embryos if that's the right thing, which it isn't for everyone. But that's not everything. And just think that Western medicine and IVF can be the answer for everything, and you can ignore your diet and exercise and self-care and emotional well-being. That's just kind of fooling yourself. It's got to all come together. And so I really appreciate what you do and what you did in your book as well. So thank you.
No, thank you. Each other. Thank you for offering your time and your care. I really love your approach, and other REs are watching so that they learn from that rather than just throwing it. It happens a lot. And in fact, I would even say some patients would request it. I don't know if your patients do that with yourself as well. There's this fallacy in believing that the more we throw at it, the more it's going to result in a positive outcome, maybe at the end. It's not necessarily that. Sometimes less is more.
I totally agree. I couldn't have said it better.
Thank you. Okay, well, it's been 20 minutes. So on lots to do. We have things to do. You have to get going home. And maybe we can talk another time in the future. And
sure.
Right, I think it'll be fun. So thank you for your contribution, and come back and watch my other posts, because there are a few other posts, and Facebook, like my page. Bye.
Thank you so much, Mary.
Oh, by the way, I have to add one more thing. So, see, book, I not have baby or pregnant woman on the cover, and I so appreciated that you also are of that same mindset.
Because
I both know sometimes looking at other babies and other bellies, it just causes more. So I love it that you're completely lying.
You are right on. Yep, you're right. Thank you.
Okay, you have a great night. So come back, and actually next week, I'm going to be. Now I've done some interviews where we have some success stories, and that's really been able to speak to some of my patients who are currently undergoing fertility issues. And her name, actually, I better not say her name right now, but there'll be a patient that's currently having issues, and she's had a miscarriage, and she's going to go through how she from business to now embracing herself as a whole. I really want to share that with you all. So check that out next PM Eastern Standard Time. And at the end, maybe you could type in your website, or if there's anybody that has a question, are you open to answering?
Oh, absolutely. Yes.
Post your whatever, your contact information, and your Instagram, Facebook, so people can follow you. Thank you
Mary,
so much for your time.
Absolutely, I loved it.
Okay, I'm going to end the podcast now. It's not ending.
It's too good.